Good morning, everyone. I think some of you guys know me already. I have the privilege of working at Cincinnati Children's in the Division of Rheumatology, and an even greater privilege to be here today to talk to you guys. I always get a little emotional because the truth is that I'm supposed to give you an introduction to systemic JIA, but the reality is that I always learn a whole bunch more from you guys when I'm here because I can tell you what the literature says and what the textbooks say, but you can tell me about the lived experience. So hopefully today we'll have dialogue at the end and we'll both learn something, I hope. So just a couple of objectives. One is just to know the most common clinical manifestations of systemic JIA. I think most of you by now know what the word biologic means, but we'll just have a little introduction about that. And then at the end, realize that the treatment options are, I will give you the most common things, but it's still being worked out what is the best way to treat these kids. So we can go back to 1868 in England, and Sir Frederick Still, his first name is George, but he goes by Frederick, described 22 children that fit the sort of the classic picture of systemic JIA. And he published about this. He published about many, many things, including other forms of chronic arthritis. So those of you that are frustrated that systemic JIA is part of the other JIA criteria, you can attribute that to Sir Frederick Still. And this is an interesting article that came out just recently in The Lancet. Some of the people in the room were part of this study, but they were looking at healthcare disparities amongst the different countries, what the phenotypes of the various types of JIA were, and who did better. So the overall prevalence in the states of JIA is between 16 and 150 per 100,000. And of that, this bar, always to the far left in each of these countries, is the amount of those 5 types of JIA that is systemic JIA. And you can see in North America, it's somewhere between 5 and 15%. In other countries like Latin America and some of the Asian countries, the amount of systemic JIA amongst all the JIA categories is much higher. They did not look at Japan, but Japan can have as much as 50% of the JIA be SJIA. Some will say that boys are a little bit more affected than girls, but for the most part it's equal. The systemic JIA can occur throughout childhood, but it's most common in the children between 1 and 5 years of age. But as some of you in the audience know, it can occur much younger than that, and it certainly can occur in the teens. These are the 5 different types of JIA, juvenile idiopathic arthritis, and this is the criteria for systemic JIA. You must have 2 weeks of a daily fever, and 3 of those days need to be a quotidian fever, and I'll show you what that looks like in just a minute. You also need arthritis, and then one of the following, either the classic evanescent rash, some big lymph nodes, big liver, big spleen, or serositis, and I'll go through what that means exactly. But this is the reason why some of you have struggled a lot with getting a diagnosis in the beginning, because this is clearly a diagnosis of exclusion, and it needs to be a fever for 2 weeks. So consequently, you suffer with a child that is pretty sick for a while. But this is not an exhaustive list, but this is some of the things that need to be excluded before you can assign the diagnosis of a systemic JIA. Infection, malignancy are the biggest ones. And then the other really big one is Kawasaki's, which I know some of you have had that on the differential before you finally got a diagnosis. So the quotidian fever curve, and I know most of you are familiar with this because you probably lived it, but it's once or twice a day, a spiking fever. When the fever returns, it actually returns below normal. And most of you will probably tell us that when your child doesn't have the fever, that they act pretty normal. In fact, those of us that don't know your child will think that they're healthy. You will say that they're still not normal, but they don't act as sick as they do when they have the fever. And often when they have the fever, they have this evanescent rash. Evanescent means it comes and goes, and the most common time to see that rash is with the fever. The other thing that makes the diagnosis tricky is that arthritis is not always a very common feature, but it's part of the diagnostic criteria. So you can see that as many as 12% don't develop arthritis. Some will just have a single joint, some will have 4 or fewer, and then 41% will have multiple joints. But because that's part of the diagnostic criteria, and yet it's not always one of the more prominent features, that also leads to your delay in diagnosis. And then on exam, when we're talking about big lymph nodes, usually they're not quite this evident, but this poor child had very big lymph nodes. She had a big liver and a big spleen. You can see that by this protuberant abdomen. She had the evanescent rash, and the other phenomenon about the rash is that it has what's called the Kebner phenomenon, which is wherever you touch, if you scrape or touch, so someone had put their hand on this child's shoulder, and the rash will pop up. And then this child did have multiple joints that had arthritis. So around all of our major organs there is a lining. It's called the serosa. So around our heart there's a serosa, around the lungs there's a serosa, in the belly there's a serosa, and itis means that it gets inflamed. So the most dangerous place that can get inflamed is the lining around the heart, and this heart should be about half this size. So between the lining and the actual heart is a lot of fluid. So it can be those serositis around the heart, it can be pleuritis around the lung, or it can be ascites in the belly. Very rarely, but can happen, you can also just get inflammation in the heart muscle, but not very common. The blood work that we get, and you probably get very familiar following this, hopefully in your My chart, but they can get profoundly anemic, but the white blood cell count is very high, and the platelet count is very high, except if you have macrophage activation syndrome. And I believe in a future talk you'll get a little bit about MAS, and I know in previous conferences you have. They also have very high inflammatory markers, and those are the C-reactive protein, or CRP, the SED and a ferritin. And if we see an elevated ferritin, that is very helpful because there are very few things that will really raise the ferritin level. But the other tests that we sometimes get for some of the other forms of JIA, the ANA, rheumatoid factor, those are most likely negative. And I believe Dr. Schulert will enlighten us some more about the use of IL-18, but in one pilot study, if the IL-18 was above a certain number, which was astronomically high, it was very specific that said that you either had adult stills or systemic juvenile arthritis. But it wasn't very specific or sensitive, so you could have a normal level and still have systemic JIA. But anyway, future will let us know the utility of that test. But in general, there's no one test that's going to tell you that your child has systemic JIA. So we're going to switch gears now a little bit to how do you treat the child once you know that they have systemic JIA. So usually they're pretty ill. I would guess that a huge percentage of you have been in the hospital when this gets diagnosed. We look at the joints, we look to see if they're anemic, we assess their heart and their lungs, and especially we look to make sure that they don't have MAS, because that would alter the treatment plan. So no secret that I'm old and been around for a while. Our original approach to the management of systemic JIA was that they got ibuprofen or Aleve or naproxen. And actually we still do use that in the beginning, especially as we're trying to sort out if you're going to meet the criteria for systemic JIA. It has very actually little effect on the fever, but so it won't mess up the quotidian fever curve. But by itself, it's very rarely satisfactory. And so then the treatment choices in the past have been, how much systemic features do they have, how much arthritis do they have, and of course, do they have MAS? And then that would sometimes direct how the therapy was given. So this is not a complete list, but this is a list of some of the more common medications that have been used to treat systemic JA. And this table can be divided into the red section are what we call disease-modifying anti-rheumatic drugs, so things like methotrexate, the steroid cyclosporin. And then the other group is now what we term biologics. So the way that those medications are made is not like methotrexate, where you take some chemicals, you mix them together, and you have this product. These biologics they're manufactured by, I'm just going to show you. So they mimic what the normal biologic system does. So normally, if you have a cytokine like IL-1 or IL-6, the way that it recruits the inflammatory cells is that it binds to a receptor on the cell surface, like this would be, let's say, IL-1, and then downstream it triggers the cell to be activated and then recruit other cells. So you can block that by either making a soluble receptor that will bind IL-1 before it gets to the receptor on the cell surface, or you can make a biologic protein against IL-1. Or the other way that you can do it, and this is the more common way for our IL-1 and IL-6 blockers, is that you can actually block the signaling of the receptor or make an antibody to the receptor rather than to the cytokine. But these are biologically engineered. They're outrageously expensive, but it does cost the pharmaceutical company a lot to manufacture them. But they have really revolutionized the treatment of all types of JA, not just systemic JA. So anakinra was the first IL-1 blockade that was produced, and it was actually manufactured to treat rheumatoid arthritis. But the truth is it doesn't really work that well for rheumatoid arthritis. But back in 2005, Virginia Pasquale decided to take healthy cells and mix the serum, so the liquid portion of the blood, with healthy cells and see what happened. And lo and behold, the production of IL-1, the gene that makes IL-1, got upregulated, and actually the expression of IL-1 was upregulated, as was IL-6 in some of these kids. So that led then to looking also to see the difference between the serum of normal and kids with JAA. So if the kid with JAA was febrile versus normal, they upregulated IL-1 much more. If the child with systemic JAA was febrile versus the afebrile ones, the upregulation of IL-1 was higher. If the child had JAA but was under control, they still upregulated IL-1 more than a normal person. So that was the introduction to say, okay, let's see what happens if we give anakinra to these kids with systemic JAA, and it was a marked response. And that was the introduction of blocking IL-1 to kids with systemic JAA. So these are the two that we use most often. Anakinra is one that actually blocks the receptor. Canakinumab, or Ilaris, is the antibody against IL-1. And IL-6 is the other one that we have. And IL-6, we know that IL-6 is important for fever. It's very involved in joint inflammation. It can lead to the growth failure, to osteoporosis, and the high platelet count and high or the low red blood cell count that we see in systemic JAA. So we also, as you know, have a protein against IL-6, which is Actemra or tocilizumab. So of the biologics that we have, those are the three that we use most commonly right at the moment. But there isn't, and I'm sure if we went around the room and asked everybody what different medications they've been on, we'll get a lot of different answers, because we really don't at the moment have a standardized approach. So, but people have tried to do that. So the American College of Rheumatology, starting in 2011, after a big consensus group and thorough review of the literature, came up with an algorithm that looks something like this to try to follow. And some of the same people that were on that panel also were part of the CARA registry, and they tried to then assess what was the practice pattern of everybody. So we have this algorithm, then who does what, and based on that, they found that the majority of the people, so at least 75% of the providers, were using either IL-1 or IL-6 blockade. And there is some good reason for that, but mind you, these things were going on somewhat simultaneously, and also were going along at the same time that we were learning more about the use of IL-1. So in 2014 was an original publication that said that that if you start with anakinra right off the bat, or IL-1 blockade right off the bat, that you put the child into remission much more quickly, and actually for some of those they were able to get off of medication. And then they had a follow-up where they had more children in this, just published a couple of months ago, in which the 5-year follow-up still shows that there are a huge percentage of the children on IL-1 blockade that are in inactive disease or in remission. But we know that that's, and then this was the original trial with canakinumab, so which showed it very quickly, the use of canakinumab in many of the kids with systemic JIA, that they also achieved some form of remission. And then the same, though, is true for tocilizumab. Many of the kids that get tocilizumab right off the bat will achieve some form of remission very early on, within the first few months. But there's still a lot of work to be known, because we know some kids respond to IL-1 blockade, some respond to IL-6 blockade, some don't respond to either, some need additional medications. So currently there is a FROST study, and actually some of this is funded by the SJIA Foundation, and so we need to stay tuned to figure out, are there ways that we can determine who would do best with which medication, and so forth. But if you have been on a roller coaster of medications, there's some reason for that, because we are just in the past 5 to 10 years really learning a lot more about how to treat these kids. And a lot of it is through our basic science researchers, and then help from our pharmaceutical company, as well as the SJIA Foundation. So I have left time for questions, hopefully. Yes. Yeah, and I'm not sure that's the thing that you want them to have, because that's old now, I think. But I don't think they care. They do have the literature, but mostly we have to sort of fight for what we think the child needs. It's
right.
Go ahead.
Yeah. Some of the insurance companies actually have, for example, if the doctor wants the child to go on Alaris, just say that's an example, they have a series of requirements of what the doctor has to try first, which have actually nothing to do with the recent literature. So I'm wondering if there is any kind of any way to, as a whole, keep informing the insurance company of a set of recommendations, so that the insurance companies as a whole, I mean, I know we don't have national health care, but they seem to be, at least the ones we're dealing with, they have an algorithm which is very clearly more associated with the cost than anything in the recent literature. And so I'm just wondering if the foundation or some other body can, if there's some way for them to kind of go to the insurance companies to make these points.
I don't know about working with the insurance company, but I do know this has become political.
Okay.
And so I know in Ohio there's a lot of work to address the step therapy, and rather than step therapy allowing us to use what we think we need to. Yes.
When you say first line. Can you read for the mic, please? Oh. When you talk just towards the end there about first line medication and that, if steroids were used to control the temperature and the rash before that, and then that next step would be the first line?
You know, it varies because there are times where we have this clinical suspicion that the child has systemic JA, but they don't necessarily meet the criteria. So in those situations, sometimes we'll use the steroids right off the bat, but at least at this institution, through the guidance of Dr. Grom and Dr. Schuler, we'll start immediately just with IL-1 or IL-6 blockade and bypass the steroids. And that has been proven to be quite effective in many of the cases. The problem is that, you know, a good percentage will respond to IL-1, but some need IL-6, and you don't necessarily know that right off the bat.
Well, does it make a difference if there was MAS at first?
Absolutely.
So the steroids then would be more appropriate after the MAS or not?
The steroids are necessary for the treatment of the MAS.
Okay, okay. So then after the steroids, then if they went to Kineret, that would be the first?
Or sometimes Kineret will help with the MAS as well, so sometimes they can be. But if MAS is part of the picture, you need big doses of steroids, sometimes even some cyclosporin, plus then underlying treatment of the systemic JA.
Thank you.